like to introduce yourself? Hi.
I will, Zoe, yeah. It's Paul Nicholson here, yeah. I'm the Deputy Director for Planned and Scheduled Care. So covering all of the kind of community teams. And I'm lead for what's called Rapid Improvement Recovery, which I'll explain later, but it's a kind of combination of things that are around quality in community services. Happy to be here.
Thanks, Paul. We also have, now this is, Joe and I have agreed this beforehand. We've also got Joe on the paddle, even though she is one of the main organisers of QI Week, as Joe is instrumental across quite a few of the work streams. But in particular is to make sure we have representation from person-centred care records. Would you like to add anything, Joe?
Not other than, as I'm glad you've introduced it like that. So I'm not a workstream lead. So I do work across. So if I can answer questions, I will. If I can't, I will take the responsibility of taking those back and finding some answers, if that's okay. So yeah, I'm Jo Evans and I'm the Continuous Improvement Manager, and I'm working with Zoe and various workstream leads, particularly involved in the person-centred care records and the rapid improvement recovery with Paul as well. Thank you.
Fabulous, Joe. And we also have Beverly Murphy with us, who sits on the Back to Good board. Is it fair to say that you're joint chair? And would you like to introduce yourself, please, Beverly?
Hi colleagues, my name is Beverly Murphy. I'm a mental health nurse by training and I'm working in the Trust as the Director of Nursing, Professions and Operations. Nice to be here this afternoon.
Right, so thank you very much. Hopefully between us we can answer any questions that you have. I hope this is a great opportunity for you to learn something, but also for the programme to take away from this. Okay, what's the bits that people are really interested in? What do we need to be communicating about? Or actually, hands up, kind of dropped the ball. We need to talk a bit more about these things and make sure that everybody's involved. So we issued some slides from all the workstream leads as kind of an aid memoir and a starter for 10 for you to have a look through and say and promote if there's any questions, anything that you would like answering. We did receive a couple of questions through that method, but equally this is a live Q&A session, so by all means we will kick off with the two that's already been asked. But just put your hands up if there's anything you want to add or if there's any follow-on questions based on where we start from. So the questions as they were received. Sorry, you can see me on the video as I'm reading from a screen and so on. Okay, so the first question.
Zoe?
Yep.
Sorry, Joe just interrupted this. I've just noticed there's a comment about service user on the panel. I don't know if you just want to reflect on, because obviously it said there were service users on the panel. Somebody just put a comment in asking about the service user representation on the panel.
Oh, sorry, apologies. Yes, we were unable to get a service user on the panel. It was a combination of asking the question, but perhaps being too late in the day to do that. So it's something that we will share and we will address further. Now, I suppose what I do want to provide assurance of, the fact that there isn't somebody in this session, what we've, as a programme, what we've been working hard to do is we've pulled together with the experience and engagement team and service users and so on, we've pulled together an engagement strategy to make sure that where involvement is required from carers across the work streams, that's requested in plenty of time and takes place. But then also, how do we communicate our progress that's been made, because there's a lot of good stuff that's been. So that is something as a programme that we have in place and we are taking forward. Okay, so back to the questions. So the first question was about physical health. So number one, and I believe Rob, I've pointed to you to answer this, but by all means, anybody step in. So number one, how are the Trust going to support every team to embed the physical health strategy into their practice when they may not have access to appropriate equipment or staff with the appropriate training and knowledge in their teams?
All right, thank you for that, and whoever sent that question in, thanks for that, because it's one of those that gets us thinking outside of my area of acute and emergency care. So if we can start on the positive, I think the immune and emergency care network, we will hopefully have the equipment and have the training in place to be able to put forward the trust strategy. We're trying to design the trust strategy as something that can be adopted by all, will have more parts to it where it's required. So for the emergency care, so the 24-hour inpatient wards where some monitoring, extra monitoring might be required for some people, that's in place. But we obviously understand for different teams in different parts of the trust that such an extensive physical health policy won't be required. But whatever we do put in will be patient-centred. It will support all our patients in all our settings and provide them with the physical health care that's required. So that's the first thing I'd like to say. To ensure that we meet the needs of every team, well, we've got to interact with every team. We've got to make sure that we speak to the representatives of all of our teams out there. Now, this, as I say, is not going to be a small piece of work because we've got a large number of teams and a large number of different services. So the first thing is the identification of who we need to speak to. We're already on with that. And then we'll assess to see what training is required within each team and what equipment, if any, is needed within each team. For example, I mean, Paul's in and he'll be able to probably answer this better than I can. But we need to assess, say, for one of our community teams, one of our community recovery teams, have they got all the equipment they need for measuring people's blood pressure and stuff like that? This is stuff that we need to ask and we need to address in each of our teams. So there may be purchases that we need to make. We may need to ensure that all the equipment is there in each team base. This is going to be different from team to team. Might be very different in ATS as it is to an acute ward, as it is to a recovery team. And other teams such as the older adult service will need variations on that as well. So it's going to be a case of we will be liaising with all the team representatives. I was going to say team manager, but it's going to be wider than the team manager. It's going to be patients, clinicians, service users representatives. So that's going to be the way we're hopefully going to get to know what people need, and then we can provide it from there. Is that a decent starter for 10? I
can add a bit, Rob, if that's helpful, just in terms
Please,
of community. Paul. Yeah. I mean, this also kind of links back to good, if you like, in terms of one of the issues that the CQC highlighted and that was incorporated in the Back to Work Good was around the maintenance of medical devices. And what's that's made us do is just what Rob said there is right. Okay, what do we need? And moreover, once we've got them, let's make sure we've got systems and processes in place that that calibrate things and put maintenance in place. I know Jonathan Mitchell's currently kind of working up kind of standard operational procedures specific for kind of team-based stuff. So what are the things, what are the assessments we need to do in terms of physical health in your particular setting, and therefore have you got the equipment to kind of to undertake that? So it feels linked up to me, I think we've got a lot of work to do in terms of the kind of, I think, the operational policies, and I know people are hard at work at that, but it does feel linked up. That you know, let's make sure we've got the right tools and the right training and clarity around the role. Will that help?
Brilliant, thanks Paul and Rob, really great answer. We've got some questions, I'll do them hands up in the order that they came along. So Helen, would you like to go first, please?
Sorry, I actually asked that question because I'm the service manager of the homeless assessment support team, and the people we work with have lots of physical health issues. Right. And we haven't got, you know, it isn't embedded in our team because we haven't got a nurse, we have got a psychiatrist 0.2, but I think there's some expectation of other workers to be able to carry out basic physical observations, I presume. My worry is that we were talking about this 2 years ago at Northlands, you know, embedding it then, and you know, we're still, well, in my opinion, we're not that much further, I think. So it's just to say that there are small teams like my team where I'd love to introduce it and embed it, but A, I don't have the equipment, and B, I don't have the possibly if nurses have to do it or doctors do it, I know in some services, or help out with the physical health reviews, so to speak. So
well, you're on my list, Helen, that's for sure. And I think we're just trying to negotiate a nurse coming across, aren't we?
Yeah, no, that's right. But I suppose what I'm saying is, it's not just the big players. It's not just the
absolutely appreciate that. Yeah,
boards or the community mental health teams. There are other services, and I'm just one. Where we're trying, but it's difficult when we're, you know,
need some support with that. Yeah, no, absolutely.
Support,
and I think in terms of a kind of homeless team, physical health will be it'll be particularly key, I would imagine, in terms of the
So that's why I raised the question.
Yeah, no, it's a good question. Lots of hands up.
I think if I could just answer, I think that's why I said all our teams, you know, we really need to get this across. And I do understand that things have been raised perhaps with the physical health stuff in the past and it hasn't really got there. But I think now with what's really been triggered by the CQC and the subsequent Back to Good work is I was going to say a proper understanding, but an urgency and a need to do this. And it's certainly something that's way up on my priorities, and I think on Jonathan Mitchell's as well. So it's certainly our intention not to forget any team and any group of service users that we've got.
That's great. Thank you.
Thanks all, and thanks Helen for kicking us off. Jenny, you had your hand up next.
I think most people know me, Jenny Wilson, Mandatory Training Lead, and sit on many of the Back to Good work streams, as training has featured in most of them. But just to say that we are working on some core physical health competencies for all staff, from diabetes, wound checks, a whole thing that absolutely everybody needs in all areas, and then looking at the specifics across every team. And then that also links into medical devices to ensure people are using them correctly and are trained. And also that we have a really robust recording system for how teams know that has happened and what needs to be reviewed and how often. So obviously you can imagine the mandatory training and all of the expiries, and we've got a huge deadline at the end of next week. I'll use this as my time to plug. Please get all your teams to update their training. We've got a week and a half. We can do this. Once I've got some headspace in November, the other stuff can really take hold for us to start working on this. And we really need to think about how things and the restructure and the changes that are going to happen in the different care networks, and where all the senior nurses and infection control, I think, will be key to how we link everything together so that physical health is and mental health is at the core of everything, but that everything's linked together, because obviously one of the huge things the CQC said is, we know you do it, you just can't prove you do it. So it's about getting it right and then being able to really easily prove that we do. Thank you.
Thanks, Jenny. Okay, I think we've covered everybody's comments. Before we move on to the next question, has anybody got anything they would like to add, chip in with? Okay, thank you. Right, so the next question. So I'm going to direct this to you, Paul, as it's a community question. So why are teams like Hast and Hit in the specialist services quadrant currently not included or involved in the rapid improvement recovery work?
Sounds like Helen again. I'm assuming there. Well, the answer is they are. So, to give you some examples of that, so one of the issues that's one of the key issues I think that's in our work stream is around lone work and the buddy system. So you know, we've reviewed all standard operational. Yeah, please. Sorry. We've reviewed all standard operation policies in terms of lone work, and so we've got some kind of standardisation and quality in that. And I know Hast and Hit contributed to that. Equally this morning, the business case for a kind of GPS device has been approved, so that'll be rolled out into places like Hast and Hit also. There's some quite generic things that I think that community teams will get linked into, including those two services around care planning and risk assessments. Now, although there were some kind of local issues that we had to address, the issues around kind of quality have moved into kind of the broader work streams. So again, we'll be benefiting from that work and helping roll that out across all teams. I mean, care plans, risk plans, aren't exclusive to any one team, are they? There were some other things around Mental Health Act training, and I know that's been rolled across both of those teams. I think I've sent something out recently just to kind of check that it hits all the kind of specific issues for any specific teams. So that's in there. The other stuff we're kind of more linked to more kind of specific things. So if you've not got any psychologists, for example, then we were challenged to look at how we keep waiting lists for psychology monitored and at standard. So if you've not got psychology in your team, then maybe that's why you've not noticed that. I'm assuming, Helen, it was, you got your hand up, that was your question. Was there anything that I've kind of missed there in particular?
It was my question, yes.
Surprise.
I like asking questions.
I know you do.
I think, Paul, it was probably, yes, I'm aware of the lone working. It's really important in our team because we're going out there working with people in the community face to face and, in some tricky areas, etc. So, yeah, I didn't realise it's badged. I suppose it's like all this back to good stuff. It's, I can remember doing lone working, but I didn't know it was underneath the umbrella of whatever it is, community recovery improvement. So that's my fault, I suppose. Not knowing that, but because I don't get involved in lots of meetings up at HR, Fullwood, etc., and I'm not in those work streams, etc. I suppose I'm like many staff. I'm not sure, which thing fits where. Do you know what I mean? So for me, it's a bit confusing, all this back to good. And it was good to read those work stream things that you sent as a part of this Q&A. Because before that, it's nice and concise. I didn't know really. I knew the CQC had sort of said we were, inadequate, but I didn't really know the detail and which area. So that was really useful. I think better communication is
simpler stuff.
important.
I mean, and I think I think you you know, in terms of the Back to Good as a work stream, I mean, I think you can kind of chunk it up a number of different ways, really, and you know, yeah, I think rapid recovery kind of was a bit of a kind of let's push together things that kind of link into the teams, but equally link wider. So yeah, I understand what you're saying, but I think you can probably chunk it up any way you want, Helen, and I think the more simpler we can communicate that, the better. Appreciate that. Yeah, it's good to raise it. It's good to raise it.
Thanks.
Okay, thank you for that. I can see that Maggie has a hand up. Have you got a question that you'd like to add or comment, please?
It's just a comment, really. So regarding the, I'm sorry, I haven't read the literature sent out beforehand. I wasn't aware of that. I must have missed it. So basically, regarding the 2 questions we've had so far, within eating disorders, we are probably a bit ahead with the physical health monitoring for obvious reasons. We are ahead on that. So, but to say that COVID has been quite challenging because we haven't been able to do nearly as much monitoring as we usually would do if it wasn't obviously for the COVID outbreak with the reduction in face-to-face appointments, but we're still doing a minimum of that. I don't know whether we have anything to offer in terms of to other teams, and that's something that we're actually already doing. I'm interested to just pick up that the CQC gave some guidance on monitoring of psychology waiting lists. I wasn't aware of that because we do have a number of waiting lists, and I think any guidance on how to monitor those waiting lists would be very beneficial. So those are just 2 points regarding what's come up so far. I think my general point is that I think it's really important. Somebody in the chat said, what is HIT and what is Hast? HIT is the home in, it needs to be defined. High intensity treatment, is it? And Hast, the homeless assessment team. I think it's really important that all of this Back to Good doesn't get too focused on exclusively on the acute wards and on the acute pathway, because I think that's the impression I've got, that a lot of the focus of the Getting Back to Good, that the priority is the acute wards, the clinical decisions unit, those services, whereas it's really got to apply to all of us across the board. It's a really vitally important agenda, that's my feeling. We've got to be all included in this Getting Back to Good work, and I know in our quadrant we're doing some peer inspections, sort of trying to get ourselves prepared, and so I hope that we can just be equally included along with the acute wards, etc. Okay, so that's my comment.
Maggie, thank you for that. And thank you for the comment, and actually thank you for raising about making sure that we do cover as many teams and areas as possible, because we are one trust and we need to get back to good. The CQC did focus on specific core areas, but I do believe that that care standards and so on will be and quality will be trying to work with as many services as possible, as you said, to do the peer assessments and get everybody as ready as possible.
Yeah.
And of course, what we want to do as a programme is where improvement actions have been identified, and it may be within a particular service, well, we'll tackle it in that service, but really, is it replicated across different areas of the trust? Well, we need to establish that, and we need to make those changes there. We need to make sure that we really embed the actions, and we don't just look at the areas that were targeted, because when the CQC come back, it might be looking in a different area, and they find that we haven't really cracked it because we've still got a similar situation elsewhere. So we really do need to look at that across the board, basically. I'm not sure who was first, Paul or Joe, so I'm going to go ladies first.
I think it was me first anyway. Thanks, Zoe. Just a couple of points from me anyway, really, and they were to do with the chat. I think what for me, something a little bit on a side, but we've been talking about, and it was me that put in there about can we explain what Hast and Hit are for those, because I think something that we fall into as an organisation, probably NHS actually, not just us at all, is using all of these acronyms, which I think, you know, to make everybody on this call feel included and throughout things, I think that's something we really need to be quite aware of. And I think even us as members of staff, clearly there's been different interpretations as to what they mean. So if we've got service users, members of the public on this call, then, you know, I think we need to just be a little bit more aware. So that was one thing. The other thing I wanted to just say, Zoe, I'm just aware that Joe Hemmingfield has put a question on that I didn't want to get lost in the chat because there's lots of different things coming through. So I'm happy to read that out for you when that's appropriate. I don't know if Paul was going to answer the previous question and then you want me to bring that in. Whatever's helpful.
I've seen that from Joe.
Oh, sorry, Zoe. I know it's hard when you're doing the whole thing, so I didn't know if you wanted me to help you. So I'll leave it with you.
Okay, Paul, would you like to add?
No, it was just to come back on Maggie in terms of the focus around inpatients versus community. So we challenge it's just to say, Maggie, we have what's called back to good lead meetings and, you know, and planning meetings and stuff, and we really challenge ourselves to say, right, okay, so we've cracked there in this service, where else do we need to kind of make sure that this is kind of important, really? So it's a kind of principle of the group, and you're right. I don't think we've got that right in the past. So yeah, it's just a reassurance, really. Okay.
Brilliant, thank you very much. So actually, as we've already introduced and billed, we've got a question from Joe Hemmingfield. Joe, I'm happy to read it out, but then by all means do step in if you want to add anything to it. So Joe's asked, what does good look like and how do we know when we are there? So I think that could be, Beverly's already smiling and nodding. I'm going to pass that one over to Beverly, please, to answer.
I think the answer to that's pretty straightforward, but getting there is a little bit more complicated. So what good looks like is something that we would be happy to receive. And if you think about it, you know, people talk about the fundamental standards of care and the CQC and how we're regulated. But I guess what I want to know is if I walk into a service or I phone a service and I ask a question, that somebody's going to greet me with a smile, they're going to listen to me carefully, they're going to try and help me. And then let's imagine I then walk into a facility, be that a ward or the community, whatever kind of service in the community, outpatient specialist in a surgery, one of our teams in ED, however it is, that actually the environment is one that is conducive to me having a conversation, that it's private, I'm able to feel dignified, that the person is really, whoever I'm talking to, the clinician I'm talking to is really interested in what I've got to say, and that they want to help me, and that I feel I can trust them, and they've got the right skills and they've got the right time. And you can see that basically what I'm saying is if you put yourself of walking through a pathway in any part of our service, you should feel confident that you're experiencing something that you would be happy with. I often say it's got to be good enough for one of my children, because I won't, my children are adults, by the way, but I won't allow them just to kind of be seen by anybody. You know, I'll absolutely control that. It's got to be right. And we have to be confident. We have to be confident it's going to be good, and it's going to be consistently good. Not that it's just good in the first part of the service that you see and then you get passed on somewhere else in the pathway and that's not so good. Consistently, we have to be open to people's needs. We have to be person-centred. It has to be about them and not our pathways. We really have to listen, and those plans, care, treatment, whatever kind of plans you call them, those plans have got to be about that person and meeting their needs and helping them to live the best and most independent life possible in the setting that's right for them. And somebody said, it might have been you, Maggie, that, you know, we talk about wards a lot, and we do talk about wards a lot, but actually for me, what good looks like is us not relying on wards, because our community care has a good and rounded offer that we support people to stay at home. Because the minute you go into a ward, you can't have a cup of tea whenever you like, you can't go to bed and get up whenever you like, you can't behave however you like. I mean, I'm kind of hamming it up to make the point, but you get what I'm saying. Your choice and your sense of agency, the minute you go into a ward, is taken away from you because of the virtue of the environments we work in and the need to maintain some safety for the whole instead of the individual. So that to me is what good looks like. Do I think it's possible under the current funding regime? Because that might be one of the comments that come back. Actually, if you look at services in other parts of the world, in fact, in other parts of the country, they do that. So why can't we do that? When you look at the benchmark for how much we are invested in as an organisation per head of the population, weighted by the demographics we've got, so for age, for sex, for background, historical background, for occupation levels, for how well supported people are financially, etc., etc. We are well funded, so it's up to us as a group of leaders to make sure that our services are shaped in such a way and that we use the investment in such a way that people consistently get that kind of response, welcome and then for onward response that I've noted. And if it's not good enough for me and it's not good enough for one of my children, then it's not good enough, actually. And I don't say that in any way to be critical. I say that as a kind of, come on, let's really think about what we do. And always, today, tomorrow, in the next hour, next week, what can we do a little bit better? Because our responsibility is to provide healthcare and always to stay focused on, and now what can we do a little bit better? So we do have two jobs. So that's my my response.
Thanks, Beverly. That's great. Jo, you've got your hand up.
Yeah, thanks, Zoe. Just listening to Beverly then, it's just reminded me of a couple of other sessions that we've run this morning as well around the peer reviews, for those of you who were able to join those ones. Because it just made me think about, well, how do we know that, we're not going to get in every service, and how do we know what's happening? And actually the proactive work that's now starting to happen with the peer reviews about actually getting groups of staff, service users to go in and kind of act as if, what if this was, if I was coming here, or if my child was coming here, or something like that, to proactively do that in the services rather than wait until we're in that situation, which hopefully, none of us want to be. But so that really kind of linked to the importance of that piece of work, actually, from that talk that I listened to this morning, and that workshop. And then the other one actually was the culture workshop that I was at earlier today as well, and about how we change the culture. And again, listening to Beverly about, it's not necessarily about just bringing more and more money in, but actually how do we use what we've got differently? How do we use what we've currently got and invest in that, and invest in time, not necessarily money? Sometimes we've got the skills, we've got what we need, we just need to reflect a little bit as to how we use them a little bit differently. And I guess that's what kind of, my key area of work, quality improvement, obviously it's at the heart of that. So it's how do we kind of look at what we've got and use things a little bit differently. So it just made me reflect, I think, just listening to Beverly there about those two, and how all of this is linking together throughout today.
Thanks, Jo. Beverly, did you want to come in again?
Yeah, can I just add a little bit onto that? So I think it's a really fantastic opportunity to use service users and carers to help us understand the quality of our services. Now, we can do that in lots of ways, formally and informally, but it's about really, really listening, because if we do a peer review, so if I go and peer review a service that one of my colleagues provides, of course, I want it to be good, don't I? And also, I'm thinking from, I've been in the NHS for 37 years, so I'm always carrying that blueprint with me. Service users are absolutely fantastic in going into teams, community bases or outpatient departments or wards and saying, well, that's all very well, but what about X and what about Y and what about Z? Because they're not hamstrung, you know, with the same restrictions that we might have, either by virtue of the fact that we work in this environment every single day, or because it's their mate's service that they're reviewing. They want it to be good. Actually, service users will say, well, this doesn't work for me. You know, so you go into a community base. Well, actually, I had no information about what bus route got me here or how often the buses run, etc., etc. You know, when you're anxious and you're going to your first appointment, it's those kind of things that make the difference, that help you get there on time and make the full use of your appointment and not arrive in a bit of a state because all the way along the line you thought you were going to be 10 minutes late. You know, we need to use the service user experience and really listen. So that we can make the changes that are necessary, because actually very often it's the dead small stuff that makes the difference to people, not the big glossy, you know, we don't buy big MRI machines and stuff like that, do we? It's the person-centered things that make the difference.
Thanks, Beverly. There's no more hands up for that. Now, I'd just like to, I'm conscious, I think we've rattled through and we've covered some really interesting topics, and we've got a last quarter of an hour, and I'd just like to, rather than going straight to pre-prepared questions, going back to those, is there anybody on the call that would like to ask anything? No? Okay, fabulous. Oh, Maggie, sorry. Oh. Maggie, would you like to ask something?
I think our challenge is to focus on what Beverly's just been saying about the good service user experience, and to manage to do that without in the process getting staff really, really stressed about, because in preparing for all these things, peer inspections, etc., it seems as if an awful lot of data is always being needed. And so in the process of collecting all that data, it's maintaining the staff morale, bearing in mind we've got COVID to cope with as well. So that's just a little perspective from where I'm sitting, because inevitably with all these things, you know, we're having, you know, has everyone got their care plan? Have they got their DRAM up to date? Is this up to date? Is that up to date? All the things that we knew we have to do, and sometimes combined with staff shortages or inevitable things that we know occur in the NHS, it's keeping the morale going as well. That's just a little comment from my corner.
Thanks, Maggie, and really appreciate that. We've got hands up from Robin Fletcher. Robin, would you like to ask or make a comment?
Hi. It's probably more of a comment and just a reflection around service users and involving them, because I think it's obviously really important. I think one of the things that we are struggling with and hoping that the Back to Good kind of work streams or projects can help with is getting service user feedback and engagement more consistent across the whole trust. It's so hard to have communication, the similar communication or engagement or a process to give feedback back to service users and carers who have been involved when there isn't some sort of protocol or way of working to it or answering to it. And at the moment, because on one side you've got CQC happening, which is very fast paced, and it has to be because we need to fix things and get things better, but also that means that there's less time to be able to do those processes. So we've got the engagement and experience team, but there aren't those like specialists or that protocol to work in different teams. So it's like, how do we have the time to do that? And I think we need to focus on that, and then how we can carry on that work around the communications and engagement with service user feedback across the trust after Back to Good work streams have gone too.
Yeah, you're absolutely right. Well, I can see a lot of people nodding, and I'm the same. Robin, I don't know if you're here from the start. I did mention that we've been doing some work on the service user and care engagement plan and so on, and how we can work together with as a programme, but work with our service users and carers. And indeed, that's something we're looking to take forward and get that feedback, as you've mentioned, and involvement and so on. And then I think you're right, you know, posing the challenge of, okay, well, when the structure of the programme has gone away, how do we make sure that all this good practice and all these things that we've done and all the communications is embedded? And that, I think that's a really good challenge.
Yeah, it's feeling positive as well, that piece of work.
Yeah, it is. I think, apologies, I can't see, I think a hand went up and went down. So I just want to check I've not missed anybody. No.
Sorry, Robin Fletcher.
Yeah, we've just been speaking. Okay, right, I will go to a question that we've received earlier then too. Okay, so right, Rob, I'm going to direct this to you, even though it's a wider question about estates, but a question we've received is, a big part of the Back to Good programme is about improving our estates. When are we likely to see changes to the wards where dormitories are used, and general ward improvements, really?
Okay. I think this is something that's ongoing, and it's quite a wide-ranging piece of work. Not only is it going to incorporate dormitories and the poor seclusion rooms, it's on our acute wards, it's going to, you know, mean better ligature assessments, better windows, better door locks, better doors, things like that. There's quite a range of things that are going to be done. Obviously, to do this, it's going to have a really big impact upon our current inpatient wards, and we won't really be able to start doing it until we've got somewhere we can move our inpatients to. So as part of this, work is going to start on Dovedale 2. I don't know if you know where Dovedale 2 is. It's at the Michael Carlisle Centre. It used to be, many years ago, it used to be a dementia ward, but then it was closed probably about just about 2003, 2004. So we're going to upgrade that and regrade it and have it as somewhere where we can move patients to whilst the work goes on the acute wards upstairs. Now, that is probably going to be completed, or should be completed, by the end of February, and it's going to be starting towards the end of November. Now, when that work is completed, that's going to enable us to start work on Burbage and Stanage. Now, I can't give you a better time scale for the work beginning on Burbage and Stanage than that, really. We're still trying to finalise how the work is going to be carried out, whether it means we're going to close one of the wards fully, whether we're going to partially close one of the wards, or whether there is any scope for the work to be done whilst the wards are still open. The latter, I don't think, is very likely at all. So I think it's most probably going to be one of the first two options. Those options being looked at closely now. So again, our focus has got to be our service users, and it's going to have to be providing the safest and the best environment we can for our service users whilst this work goes on. That's currently in the hands of the estate department. So when that's finalised, we'll be able to let you know. But the work on Dovedale 2 is going to start towards the end of next month. It's going to be completed by February, and that's then going to allow us to move some patients from the upstairs wards to downstairs. And also at this point, it provides us with some great opportunities. we might be able to go single sex at this time. You know, we might be able to move things around so we can go single sex. Again, it depends on the estate's point of view on what we can fit in where. But it's going to be done. It's going to probably start from February onwards. The exact details of it I can't give you, but it does afford us some great opportunities moving forwards. Is that a decent answer?
Absolutely, thank you. Beverly, you offered to add to it. Is there anything you would like to comment on?
I think Rob did a really great job and covered it all. I'd pick out one more specific within that. So, Rob, you mentioned the dormitories, actually two more specifics. One is that we really have to address the seclusion rooms. Now, you know, I hope that, you know, in the future, when I'm on one of these events, we won't need to talk about seclusion room, because the approach to our treatment will reduce and possibly even eradicate the need for them. But right now, we are still somewhat dependent on them, and they're not fit for purpose, not for the people who we are isolating, and not for the staff. So we absolutely have to get that right within the programme, and it's all within the programme that Rob outlined. And also some of the, I think it's particularly on Burbage, the clinical room is not fit, so it doesn't allow for full and dignified assessments of people's physical health. So that absolutely needs to be looked at. But Dr. Verity gets 10 out of 10.
Gold star, Dr. Verity.
If I can just add something that Beverly said that just jogged my memory. When we do look at this, and if we can move to going to single sex, which has been very much spoken about and is our aim, we might be able to even look towards a reduced amount of seclusion, because looking towards increased green room provision, which will hopefully prevent people from having to go into seclusion. So really changing the emphasis and the focus of the inpatient wards, and I think we would all appreciate that.
Great stuff. Thanks, Rob. Anybody got any further comments on that or questions? No. Okay. I think we've got time for just one more question before we wrap up. So we've had a question in, and it's: how can staff working in supportive corporate functions contribute to the Back to Good programme if they're not involved in delivering care? So I'm not sure how many corporate colleagues we've got on this call, but yes, the focus has been on more of your frontline services. So how can we have everybody involved? So as our panel member, David Walsh, I'm going to say you're representing corporate services, and would you like to take that, please?
Yeah, certainly. And yeah, you're right. There may not be many corporate people on the call, but I don't think that's really matters, because actually it's relevant across everybody. That, you know, there may be people who feel, how can I contribute because I'm not directly involved, and it's encouraging that there's a willingness for people to be involved if they don't feel they are already. I think the important thing to state is that the Back to Good programme isn't like a train that's kind of pulled into the station, and if you don't get on board, then you miss it and you miss the opportunity. It's about continuous improvement onwards, and it's about something that's going to be going on beyond the period of the programme itself. I mean, hopefully we will achieve everything we want to achieve in our Back to Good programme, and if we do, then the things that we set out to address should be addressed. And obviously we need to make sure we don't take our eye off the ball in other areas, so that we can get to where we want to be. But the improvement will continue always beyond that as well. And I think the short answer as to how people can get involved is to engage with it. There was a comment earlier, I think it was Helen who mentioned earlier that she'd been involved in something and perhaps hadn't realised that it was under the auspices of the Back to Good programme, that it was badged as Back to Good. And there will be things happening and things changing, whether it's the way that we do something in a service, whether it's the way that a meeting happens. There'll be things that are happening differently, and they're happening differently for a reason, and it's because of that programme, because of the changes that we're trying to implement. So I think engaging with it is the best way of being part of the journey. And like I say, you won't miss that train, because it's kind of, it's ever moving for all of us to be on, and beyond Back to Good, there'll be other opportunities for people to improve stuff, because you never reach perfection and sit still. You have to keep on moving with it to continue to improve.
Thanks, David. Joe, would you like to come in?
Yeah, thanks, Bev. Zoe, I think it was just on the back of what David was saying, really. I think it goes back to something we were talking about earlier about communication and about, so great, I totally hear what you're saying, David, and I really like that kind of analogy about the train. But I think people might be thinking, you know, but how do I get on that train if I can't carry on with that? So I want to get on it, but at what point, you know, how can I get on it? Because it seems to be moving past me if I keep using that. So I think maybe there's something around kind of, you know, hopefully from this is, as you've said, Zoe, you know, it's not for the want of trying, and that's what these kind of sessions are about, is feedback as to, you know, what would work better, I guess, in terms of that communication, in terms of where we're up to, where we're at, but also if people do want to get involved, you know, how can they, and being able to just improve community. And it's not just about the Back to Good, obviously communication across, you know, with everything that's come up, I think in every session I've been at so far. So I think it is a little bit more about that culture again, isn't it, of our organisation, about how people feel that they can get involved. And I noticed that Maggie's put on there about kind of service users and staff feeling really valued, feeling more valued. And I think, you know, that a lot of that is simply down to communication, I think, and making people feel that they can be part of it. So it was just to kind of, you know, add on to that, I think.
And I think if I could come in terms of how can people get involved, we would like as many people involved as possible in terms of these work streams. I think what I'm going to recommend is we have the fortnightly Back to Good email communication that goes out. We'll put details in there again in terms of work stream leads, when we meet, what we do, and then you'll have all the information that's needed, if that would be useful. Joe?
Sorry, Zoe. Just a final point actually as well is obviously in terms of this week, people hopefully have seen that we've, you know, our comms team have been amazing in supporting us with getting things onto the website, to again make that accessible not only to staff internally but to people, you know, who hopefully are on these meetings, these workshops as well externally. So I guess again there has been some extra things added on there, and again, Zoe, if there's anything there that you know, perhaps the presentations and things that we've sent out, if they can go onto that website, if that's been felt that they're quite clear and concise messages, maybe we can, you know, work on there as well. So yeah, absolutely.
Fabulous. Yep.
Thank you.
Right. Well, I'm going to draw this event to a close. I think that's been a really good hour. I really enjoyed it. I really hope that you find that valuable too. And thank you all for your input and your discussion. It's been really, really valuable, and something that hopefully you've got new information and learned from, and definitely from a programme, there's things that we can take forward. So if there's anything at all that you think of once this session's finished, by all means, email the Back to Good mailbox, and we can make sure that we can pick up any questions, any comments, and so on. Or if you have an amazing idea of what we can be doing anyway going forward, it's always there, and we can make sure that it gets to the right people. So I'd like to thank all the panel members, Joe, Beverly, Robert, Paul and David. Thank you ever so much. And I'd like to thank all of you for your contribution. I hope you all have a lovely, lovely evening.
Thanks very much, Zoe.
Thank you. Bye.
Thanks all.
Thank you. Bye. Thank you. Bye.
Bye.